Well, I think what we're going to do next is talk about hepatitis C in women, because there's actually been some new data, and I was hoping that there would be some new guidelines that were being released. So stay tuned. Expect to see some national guidelines on the topic in the coming months. So those are my disclosures, and just to go over the objectives, just want to review the routes of transmission, and particularly talk about the likelihood of perinatal transmission and how you would counsel a woman who's pregnant with Hep C in terms of the modes of delivery and the health of her baby. And then I also want to go over the pros and cons of screening for Hep C in pregnant women, because there is some discrepancy with like Hep B, for example. So first of all, I just wanted to go over a big picture epidemiology of hepatitis C in the United States. What this shows on the top graph there is the incidence of hepatitis C. So in the early 2000s, there was a big push for screening, the blood supply, there are needle exchange programs, and the incidence of Hep C came way down and was steady there for about a decade. And then starting around 2010, started to see an uptick, and so we're almost back to where we were 2000. And then if you look at the panel below, it takes a deeper dive into the age groups where this is happening, and what you see is it's mostly in young people. So the blue bar there are folks who are 20 to 29 at the time of their diagnosis, and then the red box is 30 to 39. That's where most of the new infections are happening. So not surprisingly, because of those age groups, it's becoming more common in women who are of childbearing age. So at baseline, the CDC was said it was anywhere between 1 to 2.5% based on which study you were looking at and things like that. However, the reported number of cases of Hep C in women of childbearing ages has essentially doubled between 2006 and 2014, from around 15,000 at baseline and then well over 31,000 in 2014. A couple other smaller studies. So for example, in Appalachia and Kentucky, at the same time period, the HCV detection rate increased 200% in women who are of childbearing age. And not surprisingly, the proportion of infants who are born to these infected women also went up 124%. So just a reminder of how you can transmit hepatitis C. The most common is through injection drug use, but down at the bottom there, you see mother to infant. So if you were talking to a woman, I think a safe number to quote is around 5% risk of transmission from the mother to the child. And I think a question I get a lot when I'm talking to pregnant women is, well, when, and would potentially like doing a C-section help drive that down? And the answer is a C-section is not recommended, because it's believed that a third to half of the transmission is occurring in utero prior to that last month of pregnancy. It's kind of a tough study to do, but there's some studies there you can refer to. And so what are some of the risk factors for transmission? Probably the biggest one is HIV co-infection. I think that's driven mostly by having a higher viral load, higher hepatitis C viral load. And there's some data that that viral load is predictive, but also a premature rupture of membranes and any kind of invasive monitoring of the pregnant woman during their labor. So how do you manage hepatitis C in pregnancy? The first thing I would tell you is that it's like a lot of things in pregnancy, the immune system changes, and so you will see some downregulation of the immune response. So not surprising to see an ALT drop, and maybe at the same time the viral load go up. Please don't monitor the viral load in that situation. It's not going to really change anything you're going to do. There's also a 20-fold increased risk of intrahepatic cholestasis of pregnancy, with a baseline between 0.2 and 2%. So I was just talking to Rex on the way up, and he said he's seen it in the most common presentation of women just complaining of itching. And sometimes on their labs, they might see a bili that's elevated, and also sometimes an elevation of their alk phos. So that's something just to be aware of. So the Society for Maternal Fetal Medicine says that C-section is not recommended for these women who are Hep C infected. Very big difference with, say, HIV. So that's a big difference. However, given some of this concern about increased transmission to the baby with invasive monitoring and premature rupture of membranes and even episiotomy, they said if you can, so please avoid those. Practical things that you can tell your patients, obviously, if they're pregnant, they should avoid alcohol for the health of the baby, but also the health of their own liver. And then the question that sometimes comes up is, well, can we do pre-exposure prophylaxis, or can we do some kind of a antiviral therapy to prevent transmission? And there is a study ongoing at the University of Pittsburgh in 20 women. We should be getting those results probably in the next couple of months. But right now, we really don't have any data in pregnant women. So the recommendations from the Society for Maternal Fetal Medicine is that if the folks are considering this, that they do it in the setting of a clinical trial. And in other words, they should just wait until after they deliver, because we just don't have that much data on the safety of these DAAs in pregnancy. So next I want to talk about outcomes of these babies who are born to hepatitis C positive women. This was a study done about 10 years ago by my colleague Steve Pergam. And we have a database here in Washington State where we track all babies that are born in the state, and he was then able to link those pregnancies and just basically see how the babies do. And he found that the babies who were born to Hep C positive women were more likely to be small for gestational age, to have a lower birth weight, and also to require admission to the NICU and sometimes require assisted ventilation. So the other thing that has been reported lately in pediatrics just a couple of months ago is that in primary care we don't do such a great job following up some of these women who are testing positive. So this comes from Magee Women's Hospital at the University of Pittsburgh. It's a 9-year study where they tracked all the women who gave birth in their system, and they knew 1,043 of them were Hep C positive, and then about a third of those women then had at least one follow-up visit for their baby in the next year. So we're talking about 323, and only of those 323, only a 95 or a 30% had the requested and recommended testing for Hep C by 18 months of age. The graph shows here is the transmission rate, which was a little bit higher than the meta-analysis that I showed you. Is not 5%, but about 8.4%. And you can see that it's going up just like it is all across the United States. So next I want to talk about screening of pregnant women for Hep C. We've had screening for Hep B for I think 2 decades. And right now the Society for Maternal Fetal Medicine recommends testing for women who are higher risk. So in any kind of injection drug use, or if they had a lot of blood transfusions. However, they don't recommend routine testing for all pregnant women. And it's really because they don't have any good cost effectiveness data of this strategy. And there's no safety data yet in these DAAs. So they're kind of waiting for some of these other trials to come out. The one thing that when I've talked to these doctors who are part of the guideline committee, they're very aware of unintended consequences. So that if you start to screen, they might jump up the C-section rate, even though it's not recommended, and they don't want to do that. So they're being quite cautious on that. A couple other things, if there is ever some consideration for treatment, I just want to remind folks that ribavirin is highly teratogenic and should not be used at all in pregnancy, and really should be used with quite a bit of caution in women of childbearing age. Fortunately, very rarely are we using that these days. So I just kind of want to put in a table format the pros and cons of routine screening. Obviously, it's a pretty simplified screen. We're already doing it for Hep B, and speaking as someone who works in the liver clinic and sees a lot of these women who are identified during a routine pregnancy, it does allow them to get engaged in care sooner. So I think it has been a benefit for those women. Also allows for linkage of care for both the mother and the baby. Make sure that that's not a 30% follow through rate, but closer to 90 or 100%. It allows us to do good counseling about liver health and behavior. You know, if they're drinking, they can be motivated to stop drinking. And we do have data of cost effectiveness for the general population. So that, you might be able to extrapolate that. Some of the cons are that Hep C does still have a stigma. We're concerned about potentially driving up costs or more interventions, like I mentioned earlier. And we're still waiting for the safety profile on these DAAs. So I'm just going to stop there and see if there's any questions or comments.